Okay, so Sean, since you are a GI fellow, I'm curious if you know what these are.
I think I know what the one is in the in the left upper quadrant. Those look like embolization coils, I think, but I don't know what this. I don't know what that is now.
Okay, excellent. Those are embolization coils over there. Anybody else have any ideas about these guys?
They look like little stacks of batteries.
Yes, that's what we were also thinking. And then, it looked a little bit like a pill cam, but not exactly like a pill cam. And didn't know why, like, you would have 3 pill cams. That didn't make any sense. So we learned that these are vibrating capsules for patients with chronic constipation. They were just FDA approved last year. Just for comparison, this is what a pill cam looks like. So it's different. It's got that little hook at the end, and it's got this other kind of configuration, as opposed to my vibrating capsules, which are like 3 little things here. And then just so we, just to complete, it's called Vibrant. It's like these little capsules here. It's patients who have failed laxatives and have chronic constipation. They basically have one every 3 to 4 days until they eat all of the pills. And they're supposed to vibrate, I guess, for 2 hours every 6 hours. And it starts only after, I think, 8 to 12 hours after the pill reaches the colon. So anyway, we learned about this new thing. And I also wanted to show you.
Wait, so like, I mean, you just finished the pack and you're done, or you have to, it's like a lifelong.
No, you keep going, because apparently your constipation comes back after the
Interesting.
Yeah. So
you think they can make it rechargeable, and then you just like.
I know that my fellows are
it.
asking, like, can you reuse it? And like, apparently they're not reusable. You just excrete them out. But most patients, I guess they did a clinical trial where they had some patients have a placebo pill and others have this vibrating capsule, and it helped in like 39% of patients to have more bowel movements and better quality of life. But we have had now a couple of cases where they're just basically not transiting through, they're getting stuck. And if they get stuck, they have to go in with colonoscopy and remove them. So here is another example. Hold on, I'm going to stop. Okay, so Sean was just asking if it gets prescribed, and I believe that these were prescribed to the patients. And this is a more kind of a dramatic example of them getting stuck. So we've seen, just in the past couple of weeks, we've seen a few cases now where they're not passing through. And this patient, she had a very like patulous kind of low cecum, and there were 10 capsules all stuck in this area of the cecum. So they're going to have to go in and get these out as well. That's all I know about it.
This is a patient who has seen multiple prior treated previously and had this finding.
My fellow is going to take the case.
Yes, go ahead. What's your name?
Hassan Shazada.
Hi, Hassan. Fantastic. Okay, great. What do you think?
Okay. Sorry, I didn't get the history before that you said. You said upper abdominal pain, or?
Sure.
Okay.
Right upper quadrant pain.
It looks like it. So I see kind of, looks like this multi-septated large mass in the right hepatic
Good.
lobe.
Good.
It looks like almost, I would think first, maybe some type of loculation. There's a little effusion on the right side as well.
Good. What's your differential?
So I would first, I'm thinking some type of abscess. And then there is, I forget the name of it, but there is, I think it's like endemic to like South American countries or something. Is it hydatid?
Hydatid. Okay, good.
Yeah, is something that I would think of.
Mm-hmm.
But at first I would worry about infection, possible abscess with reactive effusion on the right side.
Good. And here's your diffusion. So there's your ADC, and let me give you, where's my high B value, DWI?
Is it top radiology, right?
Is it, oh yeah, they're right. That's right. Here.
Okay, so it looks
so these little,
and then on
here's your ADC.
Okay, so they did restrict. So it looks like
Yep.
we have some hypercellular fluids. I think and probably looks more like infection.
Good. So this is this is a appearance of Klebsiella abscess.
Okay.
Klebsiella
What's that
abscess.
sign? I remember Victoria
Yes.
talking about a
Yes,
sign.
I forget what the sign is that she said.
Tortoise sign or
Oh,
something.
what is it?
Is it tortoise?
Tortoise. It was, yes, that's right. It was tortoise sign. And so the other differential is hydatid, like you said. So I learned that this can lead to, so it's an abscess infected by Klebsiella, usually apparently from like Southeast Asian descent. Patient is Thai, and they are predisposed to getting septic emboli, so it can go into the lungs and cause septic pneumonia, apparently also to the optic artery for some reason. And they can be from diverticulitis or pneumonia or enteritis. This patient had prior antibiotics treatment, so there was no active enterocolitis on the imaging that we had. And this is the typical appearance of it. So the other differential is hydatid, like you said, and you can have daughter cyst. So the difference is with hydatid, the daughter cyst, the septate enhance like here, and like the more, so the look is a little different. And whereas with a Klebsiella, it's more kind of everything is enhanced except the pockets of abscesses. What else? So if they do get, they, like I said, are predisposed to getting portal vein thrombus, and it's a thrombophlebitis, an infectious thrombophlebitis. So you have to treat the main source, the infection, because anticoagulation will not work because you have to get rid of the infection before you can effectively treat the thrombophlebitis. And I learned that when you culture Klebsiella, it has a gooey appearance. So that's why it has this mucousy appearance on imaging because of the nature of Klebsiella.
And Nelly, can I share my screen for a sec? Because I want to show
Yeah.
you. Actually, it's not the tortoise sign, it's the turquoise sign. So, and then I couldn't remember, why is it the turquoise sign? So this is, oh shoot, sorry. Here it is. Do you guys see this? So, are you guys seeing it? My turquoise.
Yeah.
Okay.
We can see the turquoise.
So it's like, I guess it's because turquoise has these like serpiginous kind of areas with bubbly areas in between that kind of look like the abscess, just like the one you just showed. Cool.
Awesome.
All right, so
Wait,
this
sorry,
is,
can you pause it again?
she forgot that she had an, yeah. So this is a, I don't know how old, 65-year-old woman, and she forgot that she had this IUD. She basically presented with pelvic pain. So this was her CT, her presenting CT. So of course there's an IUD, but there's also like thickening of the endometrium, or that what was called on CT, because this measures higher than simple fluid attenuation. So let me show you so there was a concern that the endometrium is thickened and abnormal for this patient's age, and you can see that there's like, almost looks like there's like enhancement of the wall or something. So it was basically, main concern was that there may be like some endometrial neoplastic process happening with the IUD in place. So you can see that now on the ultrasound, there's distension of the endometrial canal. There's some low-level internal echoes, maybe like a little bit of blood products or like debris floating. But basically the IUD is like free floating within the endometrium. And it's because you can kind of see the thread of the IUD also kind of gathered at the cervical os. And then there's like this abrupt caliber change right at the cervix. So she has developed cervical stenosis, and then that's obstructing her endometrial canal, and there's like fluid in there, and the IUD is basically floating in there. So that's what, it's not like a neoplastic process. The endometrium is like pretty thinned out and atrophic and compatible with their age. So I thought this was an interesting case.
Yeah, I've had 2 cases where IUDs were left in for a long time, but one, the classic boards question is like what infection is involved, can be involved with IUDs, and that's actinomycosis.
Yeah.
And then I had another one where like a Lippy's loop was left in place, and the patient developed endometrial cancer. And I looked it up, and it said like over time, like it can cause like, chronic irritation. So leaving it in, into the postmenopausal state can slightly increase your risk for malignancy.
Yeah. That's all right. So this guy, he's got a history of prior surgery, and I can go ahead and tell you guys, he's had like prior history of Nissen's fundoplication. So he presented with like vomiting, unable to keep anything down for 1 day. So this is a CT in the ED, and you can, if you start following the esophagus, you kind of see this area, which is pretty kind of thickened. But on the axial, like we're used to looking at a Nissen's, like that mild swirled appearance, you kind of don't see that. And then in addition, there's this like large area of like, probably like, it has like walls similar to the stomach, but it's like a very thinned out area, and there's like a fluid gas level in there. So that's not normal. And then when you try to look at like different orientations, you can kind of see that they're like this swirl pattern, which I think you can still attribute to a Nissen's fundoplication. But this area, which is like severely dilated, is not normal, and it's very thin walled. There may be like areas of, let me put on long windows, possible kind of pneumatosis or pseudopneumatosis starting to occur. So question was raised whether there's like there's an obstructing mass here that's causing obstruction. But then the question was, what exactly is this obstructing? Because this does not look like normal anatomy. So the goat actually read this, and if everybody should know who I'm talking about. And there's like a good story about the goat pop culture reference too. If you have time, I will tell you guys about it. Yeah, so she said that there's probably like herniated part of the stomach that's like herniated through the Nissen's fundoplication and gone into the lesser sac and is now present in the gastrohepatic ligament. Let me show you guys that finding on the coronal as well. And this was taken to the OR, and this was actually herniated part of the gastric body through the Nissen's plication. So this is the first time I'm like seeing a case like this. And if you pull up like case reports, it looks identical, like this appearance where you can see this like big bubble in the gastrohepatic ligament, and basically the part of the stomach kind of herniates through the Nissen's wrap, and it gets obstructed. It's basically like a closed obstruction. And when they went into the OR, this was like ischemic, but still viable. So they were able to take down the plication and free this part of the stomach.
Very nice.
Yeah.
Well,
I thought it was actually kind of like this is a case like in like different time points. So I'm going to start by the initial presentation. So this is a 39-year-old woman, and this is her initial CT at the start of her problems. And you can see that there's like large cystic and solid mass, which is arising from the left ovary. And I can tell you guys there's a little bit of like peritoneal carcinomatosis too there. And this was taken out, and this came as immature mixed germ cell tumor. So this was taken out, and I can show you that on the coronal as well. Nice mixed solid and cystic mass. It has like few specks of calcifications in it too. some peritoneal carcinomatosis. So this is her follow-up, 3 months post-surgery. And you can see that there are like these large deposits and in large amount of ascites, which is malignant, associated, and this was called as peritoneal carcinomatosis. This patient was, started on chemotherapy, and additional deposits kind of like everywhere in the abdomen. So this was 3 months post, and then let me think, how did I go this way or that way? I think this way. So this is from this CT, this is like 3 months post, and you can see that after the chemotherapy, the deposits have slightly decreased in size. The ascites has gotten better. So looks like some response to treatment, but there are still some deposits in the abdomen. Fast forward 6 months later, and I had the opportunity to read the CT, and I did not make that diagnosis. So I full disclosure. So you can see that these deposits have again increased in size. This patient is still on chemotherapy, and then there's like this weird appearance of these deposits now. Not only these are low attenuation, it almost looks like there's like fat in these deposits. And then there's like more calcifications in these deposits too. So I
Growing
did not.
teratoma syndrome?
Yes. So this is a case of conversion of an immature to a mature teratoma, which is like, it's also called chemotherapy-induced reconversion syndrome or growing teratoma syndrome. And the important point to pick up this on imaging, not only because of you can see like changes in imaging features, the fat and the calcifications, but there are management implications. So it's important to pick that up on imaging because there's no role of chemotherapy. If you keep, like I called it disease progression. This is like totally opposite because I thought these were like getting worse, getting bigger. They're more in number. They're everywhere. But important is to pick up the change in imaging features so that they can debulk this patient rather than just keep like trying on different types of chemotherapy, because that's not going to work. So they debulked her, and this is like a post, like after somebody read this after me and they picked up the diagnosis and sent me an email. So I got to learn as well.
The goat.
Yeah, the goat. So yeah, so she was debulked, and her latest, I ran out of space, so I couldn't show you the post debulking, but she's doing okay now, and all the deposits have been removed.
So can you, based on imaging, differentiate growing teratoma syndrome versus disease progression?
Just because, like, see how, like, so initially these deposits were like, they did not have fat in them. They have, not only they have like more low attenuation and areas of fat in them, but they also have like more calcifications. So the change in imaging features you can suggest, and this commonly happens in men, and rarely happens in women too. So
I had a case of this, and it was basically when you have these germ cell tumors, they tend to have multiple different kinds of components, like embryonal cell, yolk sac, teratoma part, whatever. And so if you see, like Nelly, that's the clue, is like if they're responding, but then one part starts growing again and it looks different than the original and more, like she's saying, like with fat, calcification, etc., then that can be the mature teratoma component that is chemo resistant but is growing, whereas all the other parts decreased.
I've seen growing teratoma syndrome in men,
Yeah.
testicular cancer, and I mean, I don't know that I've seen fat in it, but it makes sense what you're saying.
And you can just bring it up too, and they could biopsy it, you know?
Yeah.
Yeah. Cool,
Instead,
great.
don't call disease progression like me.
Great.
I think it's totally reasonable. I mean, I don't think it was
I mean,
like
but it has like management implications. So, you know, instead of like, okay, I call disease progression, they're like not thinking, and they're just going to put her on a different chemotherapy regimen.
Yeah.
So, it's not going to work. So I think it's important to kind of at least think about that. It can happen in women too. All right, that's
Great, Kate.
all from me. Thank you.
Okay. All right. So this is an interesting case. I'm going to withhold the history. Let me, if I do this, can you see the lesion?
Go.
Okay. So you see the lesion, right?
Yep. T2
Okay. So
brain
anybody
and
having?
delayed enhancement.
Okay. So what would you say?
Is there any history of liver disease? The liver looks a little abnormal.
I'm going to withhold all the information. This is the
There's a lot of
case
like
you get.
T2 hypointense signal of the liver,
Like iron.
iron, yeah, and spleen too.
Okay.
So
But the lesion.
the lesion, maybe like in the cholangio spectrum. Hemangioma, it doesn't look to be
Hemangioma,
bright enough.
yeah.
for hemangioma.
There's that rim enhancement thing.
Yeah.
Right.
Yeah, right
Yeah.
there.
All right. Good. You didn't
Yeah.
fall. You didn't fall, you guys. The story, the history is this patient had a liver transplant for intrahepatic cholangio, and this is just a massive recurrence after that. So there are only a few centers in the country that do transplant for cholangio. Like Mayo does a lot. Well,
Period.
relatively a lot, but
A few.
Right. So I think Mayo, actually, Nelly, does only Rochester do it, or you guys?
No, we've done it. We've done
You
it.
guys-
But I spoke to our transplant director and he said we've only done a few because they don't get exception points. So they
Right.
don't get on the list very high compared to HCC. So it's not that they can't, it's just that they're not ranked high enough.
Right. So this unfortunate patient, anyway, so that's just, but this is a good example that small cholangiomas can be very, very sneaky and really, like, right, if you look just on this, you could say, oh, maybe it's some sort of funny flash filling hemangioma, which I have been fooled before and thought, right, like sort of T2 bright, right? But anyway, so this is something to be aware of.
So is the T2
Sharing.
signal, is it just kind of a little bit of a pitfall just because the background liver is so hypointense?
That's what I was thinking, that it looks even brighter
Yeah.
because the background is darker. But if you had that in a regular liver, it would probably look gray.
Yeah, but if you look at the, right, hold on, let me just go, wait, I lost my share screen. Okay, stop. There was a cyst somewhere here. There. See how much brighter it is? So it's still not like even close to being as bright as this is. Now, it's true that like when you have really heavy T2 rating, the hemangiomas won't be just as bright as, but they're going to be close to cyst. But this is more of like evil grave tumor that Aarti loves to reference.
Yeah, the CSF is a pretty good comparison then, just to
right.
keep
And
you
you can see.
calibrated.
Right. So this is like, even though it's more intermediate signal, not really bright enough. And that's what I found like to be like the most kind of thing that helps you is the fact that you don't have that that the T2 signal is just off. Otherwise, it can really look like a flash-filling hemangioma. Okay, this is my next case. This is something that I've only talked about in the conference, but never seen in real life. What do you guys think?
Wow, there's like cystic things all over.
Right. But what would you think about these cystic things?
Can you scroll through the coronal T2? There's like complex soft tissue stuff in it. Oh wait, or is that the? Let me see.
No, so this is after sampling. So the pre-sampling I only have MRCP. So this is after sampling. There's a little bit of blood in there.
Oh, okay.
Let me for a second. All right, let me just do this.
Some of them almost look like serous cystadenomas to me.
Right. So
And if you have multiple serous
you're
cystadenomas, you think about von Hippel-Lindau.
brilliant. These ended up being serous cystadenomas, but
Is it
not
recording?
But this one,
Yeah, it's recording.
so this one, right? This, especially this one, I'm afraid to do anything. This one, right? This one was resected,
We're not seeing
right?
you pointed anything.
What do you mean?
Oh, wait, where's? Are you pointing at something?
You should be seeing my screen. No?
I see your screen.
Okay, now I see.
Okay. So these were not resected, but this thing was, and this is serous cystadenoma with like macrocystic degeneration. So this is oligocystic cystadenoma, which I've only read about. I've never seen one in real life. So these are, we keep following, and they just, you know, so far they're stable. But this one was resected because we thought maybe this is mucinous, because it's really not microcystic, and this ended up being that oligocystic variant, which in imaging really can't.
I have some comments here. So I would not put MCN in here because this has a lobulated border, and MCNs have a capsule and should not have a lobulated border. And they're usually in the body tail junction. Number two, they could have aspirated it before resecting it, but in which case the MCN will have a high CEA and serous cystadenomas won't. And about 10% of serous cystadenomas are oligocystic. So in this case, because we have multiple and we're thinking maybe VHL, like that, you know, you can think about serous cystadenomas, but I've had several cases where it looks just like maybe a big IPMN, and they can have overlapping features. So when I see something that looks kind of oligocystic, like it has like, you know, a big cyst with maybe a couple of baby cysts along the edge, lobulated border, no capsule, I bring up, it could be oligocystic serous cystadenoma or an IPMN, and then they can sample it and see if the CEA is elevated.
Cool.
Yeah, but I've been definitely tricked by this before. So it's in my AIRP pancreatic cyst lecture now.
Oh, cool. All right. Let's see, next case. This is a weird thing. I don't think you can actually, you know, make a diagnosis. You can see it's not an ISA, right? This is just very cystic, lobulated mass. If we look on coronals, you can see like
It's like
almost
extrahepatic
acidic.
or invading. I don't know. It doesn't look like
Right.
it's intraparenchymal.
Right. I agree. That's what it looks like. And here's the pre-axial. This is post, and then this is like more post. So it's just like an odd appearance of a, you know, relatively common. This is obvious, you know, like when something looks like this, only you can do is describe it and biopsy it. This is resected, and this is intrahepatic cholangio, fully differentiated intrahepatic cholangio. And the cool part is that this is 10 years ago, and the patient is doing well, even though this was like extra capsule extension and everything. But the patient is doing very well.
Wow, it even has like those little satellite lesions, so you'd think it would be then
Right.
really differentiated. So it has like, yeah, those aggressive features.
Right. All right, and then my last case, not an eye test. You can see that there's a mass in the vagina right there. I can just extend it here. You can see kind of heterogeneous, you know, obviously there. So, and this is it on the post. This is an older case. I don't have diffusion. You can see that. That's what it looks like. And then here's the sagittal. Avidly enhancing. Any thoughts?
Vaginal.
Well, the T2 signal.
Oh, sorry, go ahead.
No, go ahead. No, I was like, I mean, the T2 signal is the evil gray. So, I mean, the benign stuff I think is lower on my list. What were you
Yeah,
gonna
I
say,
feel like
Aarti?
it's something malignant, and you can get melanoma in your vagina, but I don't see T1 hyperintensity here. You can
Right.
get sarcomas.
Right. So it's very, very hypervascular. I mean, that's the clue. I mean, this is like basically a once in a lifetime situation.
Angiosarcoma.
Like I would.
Angiosarcoma.
No. That'd be even cooler. No, this is primary
Mixed-waste sarcoma.
neuroendocrine tumor. primary neuroendocrine tumor of vagina.
Oh, I was gonna say neuroendocrine tumor, but I was like, nah.
I know, right? Like this is like a nah, can't be kind of situation. But yeah, that's what it was. It was a primary neuroendocrine tumor. That was the only site of the disease, and it was.
Which makes me realize you can get it literally in any organ in the body.
Everywhere, yeah.
You can, but like, how often do you see?
Yeah.
Can you stick around for this next case, Victoria?
Sure.
So this was an outside interpretation, and so we don't have all the sequences, but we have the key ones. So here, patient with history of hepatitis B.
Hepatitis B. Oy.
Hep B, yep, Hep B.
So
And
there's
then that's your T2. Here's your pre. Here's arterial, or it's maybe a little bit late. And then here, sorry, that was equilibrium. This is your arterial. Wait, it's a crap. Sorry. It's not. All right. I think this looks like kind of arterial. Yeah, late arterial portovenous maybe. Okay, so it's this thing. And then equilibrium.
so there's like branching tumor in vein there.
Yes, there's LRTIV. Good. Evil gray. What's that?
No, I'm listening.
And it doesn't
Lymphadenopathy.
have your, what's that?
Lymphadenopathy.
Yep. Extrahepatic disease. So this was neuroendocrine tumor.
Ooh.
Neuroendocrine tumor.
I have a question about say say this was not neuroendocrine tumor. Let's just say we were reading this. I feel like a lot of times when there's infiltrative HCC with tumor in vein, we don't get good arterial enhancement. And my theory was that it's because the portal vein, because the tumor is in the portal vein, the hepatic artery is like, trying to save the liver, and so it doesn't hypervascularize the tumor as much. Is that theory just like, is that not a good explanation?
No, so possibly at least that's a component of it, but the explanation that I read was that once you get to that infiltrative appearance stage, the tumors become switched to glycolytic metabolism, and they actually lose hypervascularity and become hypovascular. Because you can have infiltrative tumors which are hypovascular without TIV.
Got it.
Nelly, I'm sorry. You said this was
Tissue
NET?
biopsy proving, yep, neuroendocrine tumor. High grade neuroendocrine tumor.
That's not good. Bad.
I have seen them invade veins, like even pancreatic ones go into like the SMV portal vein. Very cool. Okay. What do you guys think?
So abdominal wall looks abnormal.
Yes.
Does this patient have a history of endometriosis?
They didn't have a known history of it, but interestingly, they did have a hysterectomy like a year ago, and the final patch showed adenomyosis. So I just thought this was like a beautiful example of like florid scar endometriomas. So they're very like T2 dark spiculated, but they do have these little T2 bright spaces in them. So like the little endometrial glandular tissue. It's nicely seen there. I'll show you the pre. So there's also like tiny little foci of T1 hyperintensity in here. Not the most beautiful example, although they do have T1 bright endometriomas in their ovary. And then these scar endometriosis can have pretty robust enhancement. That's not necessarily malignant degeneration. They're just inducing a lot of fibrosis. So the fibrosis can enhance. So yeah, these were actually resected because they were causing a lot of symptomatic pain, and came back scar endometriomas.
I have a couple of teaching points about abdominal wall, deep endometriosis. So like our surgeons, gynecology, they want to know if it's involving the anterior and posterior sheath. And so we actually have to give them specific information. So if they said that if it penetrates the posterior sheath, then she would like approach it robotically. And if there was a large fascial defect, then they would get a general surgeon involved to place a mesh robotically. So if it's not involving the posterior sheath of the rectus, then she can do a mini lap incision and remove the lesion directly. So now when I see it, I'll mention the extent or involvement of the posterior sheath.
Okay, so if this is the rectus, this is the anterior sheath, and then this is the posterior sheath, correct?
Yes, yeah.
This one is only involving the anterior sheath.
Anterior, yeah.
But on this side, I don't know, it seems to go maybe through the muscle. The muscle is much thinner on this side.
Yeah, I would mention that posterior sheath may be involved.
Yeah, totally. It's bulging here. I have another point. So whenever we see these scarring or like scar-like masses in the abdominal wall, we think about endometriosis as well as desmoid tumors. And we did a biopsy of one and it came back with fibrosis, and they said basically non-specific fibrosis. And then we went back and said, like endometrioma is in the differential, and then they did ER/PR stains, so estrogen progesterone stains, and it came back positive. So then they were able to definitively say that it was endometriosis. So now when I do the biopsy, I make sure that we should put it in the differential, and two, make sure your pathologists know, because they might do those extra stains. I had a very similar case in the bladder where there was this fungating mass in the bladder. It kept coming back fibrosis, all the biopsies. Then we brought up endometriosis. They did the ER/PR stains. They were positive, and they were able to say that it was endometriosis. So just make sure you keep it in your differential and let your pathologist know as well. Okay.
Awesome cases.
Yeah.
But okay, so you can see this here. The CT was done for cough. Patient does have a history of renal cell, which was removed, which was at some point removed like years ago. He's just under observation. So you can see here, the colonic, like there's like a focal thickening of the colon with almost like stuff coming out. And I'm gonna go to and you can see here, right? You can see here, there's actually an intussusception. But this is non-conscious CT. It was done for just chest findings. This is completely incidental, right? But it does look very much like it's a tumor. So I went back and I start looking at the prior, and this is his prior MR. You can actually see it right here. It's his evil grave tumor right there. And you can actually see it on contrast there. And I actually went back and I looked through a bunch of his renal, like follow-up MRs. And you can see it here, right here. And you can see it for about 2 years. And then you can see it slowly growing. And, it's a tough diagnosis to make, right? Because, this is done for renal cell carcinoma follow-up. So, we kind of always focus on the question at hand. It's just a reminder that sometimes people can have more than one cancer.
Yeah, this is a really good reminder, because I've seen a lot of colon cancers missed. And so I always tell my residents, like on CT, make sure you follow the whole colon, like from, I do it in reverse. And then I think on MR, even more so, people tend to like sort of not look at the colon, because it's harder to even pick something. Right. But in retrospect, it's always like super clear. So I think it's a good reminder. And colon cancer is on the rise in younger patients. So I think we should remember to follow the whole colon on both CT and MR. Good reminder.
Okay.
Hey, awesome cases, guys. See you later.
Thanks all.